21st, and this is a joint committee meeting with Health Human Services, our first of the year. Thanks for doing this with us. And we have with us Ashley Berliner from Agency of Human Services. And we're going to be talking about sort of plans and ideas and thoughts and brainstorming about possibly federal funding that might be decreased and what we're doing as a state to prepare for such eventuality if it happens. So thanks for joining us.
Who's joining?
Who's joining?
She's muted.
It's Ashley's phone, maybe. Usually has a separate.
Oh, for her.
Yeah.
Are you able to hear us, Ashley? Okay.
Yeah, she's.
Is that your
for
phone?
her audio.
She's muted right
Let's-
now.
Yeah.
Let's give her a moment.
She doesn't have a
We all
Wi-Fi, so she-
suffer technology sometimes.
Mhm. Why don't we take just a quick run around the room, around the table at least, and do introductions? This time we've had a joint hearing, so why don't we start right over here with you, Esme?
Hey, I'm Rep. Esme Cole, Hartford, and I'm on the House Committee on Human Services.
Good afternoon, I'm Dan Noyes. I'm on Human Services and represent Woolgate, Hyde Park, Johnson, and Belvis.
My name is Zahn Eastis, and I'm on Human Services, and I serve Guilford and Vernon at the bottom of the state.
Doug Bishop on Human Services, and I represent Colchester's Chittenden 20 District.
I'm sorry. I was just gonna say, while let's committee assistants.
My name's Kristen Barrett, and I'm the committee assistant for House Healthcare. We're North Human Services Committee Assistant.
Brenda Steady, Human Services, East Milton, Westford.
I'm Jubilee McGill, and I too am on House Human Services, and I represent Bridport, Middlebury, New Haven, and Weybridge.
Hi, everyone. Ray Garofano. I represent Essex and Essex Junction, and I'm on Human Services.
Hi, good afternoon, Teresa Wood from Waterbury. I also represent Bolton, Beals, Gore, and Huntington, and I'm Chair of Human Services.
And I'm Alyssa Black. I represent the northern part of Essex, right above Representative Garofano's district, and I'm Chair of House Healthcare.
I'm Topper McFarland, I represent Barrytown and part of Williamstown. And I sit next to the chair of the Healthcare Committee.
My right-hand man.
I am Daisy Verbeco, and I sit next to the vice chair of the Healthcare Committee. I represent the fine city of Winooski.
Mari Cordes, I represent Lincoln, Bristol, Moncton, and Starksboro.
Leslie Goldman, I represent Window 3, Rockingham, Westminster, and Brookline, which is the Bells Falls area.
And I'm Woody Page, I'm in healthcare, and I represent Newport.
Brian Gina from Burlington. I represent the East District and part of the Old North End.
Debbie Towers, from Waterford, and also represent Barnet.
Alan Barr, I'm on healthcare. I represent Enosburg and Montgomery.
And are you two able to see there? Because feel free to move your chairs up. Okay, great. All right, Ashley. Thanks for joining us. Looking forward to hearing from you.
Thank you.
Oh, good.
Great, we can hear you.
I just want to make sure you can hear me. Is that okay?
Yeah, we can hear you.
Okay, great. Sorry about that. And thank you for buying me some time. So I am here today to answer any questions you have, but before, I'm sorry, I'm out of practice. For the record, Ashley Berliner, I'm the Director of Medicaid Policy for the Agency of Human Services. And I have a slide deck that I got in late. I apologize for not getting this to you in advance, but I hope to go through it with you, and then you will have it in your records to refer to as you want, though I'll note this is a very dynamic topic, thinking about what's happening in the federal government right now. So it might be of limited use in a couple of days. but this is what we have been going off of at the agency to understand what the different federal proposals are being looked at and how they potentially impact Vermont. So
And
I'll
it
go
is-
into that, but
It is posted on Healthcare's website
Human Services.
and Human Services, so we can follow along with you. Thank you.
wonderful. And I do hope that this can be a conversation. So please interrupt at any time and we can get into anything beyond what's in the slide. I just put together a couple of things that I thought would be of interest to these committees, but happy to go in whatever direction you want. So I will share my screen. And you can see that?
We can.
Great. So at first, this is a lot to go over. I'll go over them one by one, but first I'm going to talk about the things that are actually getting traction in DC right now. There's a whole long list of things that have been put out there for everyone to react to. It's a bit overwhelming, but I want to start by focusing on what we're hearing is actually being dissected in Congress and is likely to make into a bill. So the first thing up here is the elimination of the new adult group, the expansion group under the Affordable Care Act. This is a 90% enhanced FMAP, the federal Medicaid annual percentage that pays an incentive FMAP for Medicaid expansion. And we think it is very likely that this will go away. This represents $80 million a year in federal funding to the state of Vermont. So if this were to be enacted, it would have to go through Congress and it would be an immediate loss of $80 million a year, their budget. And I'll also just say, these are big numbers. This is a pretty overwhelming topic to think about. So just keep that in mind as we walk through this depressing document. The next change or proposal here is related to FMAP formula. Every year we get an FMAP formula. It's based on a variety of variables, including per capita income. It is published annually by the federal government, and it swings our FMAP anywhere from a couple of percentage points, 55% federal funding, 45% state funding. The annual FMAP change swings us about 2 percentage points at any given year around that 55% federal share. There are conversations happening right now, very vague, very high level, about making changes to that FMAP formula. And so all we know at this time is that 1 percentage point for FMAP represents approximately $18 to $19 million per year in federal funding per point. So if we're talking about a 5-point swing in an FMAP formula, that's $100 million a year. We thought that this might be the best way to reflect this for you because we just don't have enough information about what this proposal is. However, we do know that it is being considered very favorably by congressional Republicans.
Yeah, may I interrupt really briefly with a question? When does we receive notification of what the state's FMAP will be? Usually late in the year, correct?
Yes, in the fall.
And does that go into effect January 1st or is that a July 1st?
It's the federal fiscal year, so it's October 1st.
Okay. So didn't we receive a small increase in our FMAP last year?
We did, and it's this constant formula, so the formula doesn't change, but the inputs change year to year. So that's why I said there's usually like anywhere between a 1 to 2% swing in either direction, up or down, in a given year, just based on, it looks at state income, it looks at benefits benefit levels that states receive. So there's a formula, but it's a constant formula. And they're talking about actually making changes to that formula that would presumably have a more drastic impact on states.
Thank you. Sorry for the interruption.
It's since you already did it once, I'm going to ask again. So Ashley, in these first few items that you look at program impact, you say limited to fiscal impact, and I'm just trying to figure out how that is really real. It doesn't seem possible that it would be limited to fiscal impact, because I have a hard time believing that we would be able to come up and backfill all of this with state funds.
Yeah, thanks for asking that question, Chair. I put it here to say that there's no direct programmatic impact as a result of losing the FMAP funding. However, of course, you're right that it's a loss of a huge amount of money to the state every year. And so that in and of itself would have programmatic impacts that would be decided within your body, you know, how the Medicaid budget is allocated. If we have a loss of $100 million, $200 million, $300 million a year, of course, that's going to have programmatic impacts. But the FMAP change in and of itself doesn't change Medicaid policy. So it's not a perfect column here, but as you see going down the list, work requirements, for example, those have direct programmatic impact versus FMAP, which is really the fiscal impact is the impact.
Thank you. I just am not wanting people who are maybe listening or in the audience to think that there wouldn't be a programmatic impact to that kind of reduction in federal funds. I mean, there would have to be some sort of changes in our Medicaid program that involved changes in covered services or covered populations, or, you know, reductions in what we pay to providers or whatever, probably some combination of all of those things. But so I just wanted to make sure that that was clear to people. Thank you.
Yes, no, so thank you for that point of reflection. I think it's a really important one, and we're going to get into that in more detail in subsequent slides. The limit of provider taxes is another one that we're hearing is getting quite a bit of traction in Congress. This is of particular concern to us because it is such a massive hit, and it is a really wonky proposal that is unlikely to get a ton of public pushback. At the kind of line level, limiting provider taxes isn't going to be viscerally upsetting to people and constituents. So it seems like it's more probable that it could go forward. Right now, we have a 6% cap on provider taxes. The proposal that I understand to be getting the most traction is reducing that 6% down to 3%, which reflects approximately $104 million a year in state match that would be lost. And if that isn't backfilled, it represents $252 million gross in cuts that would be needed. So this is a really big one. And essentially, we're charging provider taxes. What we are taking in provider taxes, we are using as the state match to claim federal match. So that's where that $104 million comes in. That's the state match that we then gross up to make $242 million, which is the total gross amount.
Ashley, is our claims tax, would that be considered a provider tax? Or
yes,
would be?
Yes.
No. I'm seeing around the room that shaking their heads that no.
Claims tax is what our claims tax is.
Yes.
That's related to the provider tax.
Okay.
I'm sorry, I can't hear Jen.
Oh,
Actually, it's Jen Carvey from Legislative Council. The claims tax is I think the chair is talking about the health insurance claims tax in Title 32. I don't think that
Oh,
is
I'm sorry.
related to the Medicaid provider tax.
Absolutely. Sorry, I misunderstood. No, this is the provider tax on hospital provider taxes, DME provider taxes, ambulance provider taxes. It's limited to particular provider groups.
Okay.
Sorry for my misunderstanding.
I just wanted to make sure that there wasn't discussion federally that something, a tax like that might also be limited.
I haven't heard anything beyond the provider taxes.
Thank you.
Okay, the next one is work requirements. This is a huge Republican talking point that under current rules is only permitted through 1115s. Under the first Trump administration, several states applied work requirements to their Medicaid program via an 1115 waiver. There's a proposal now that would seek to create mandatory national work requirements in order to be on Medicaid. We don't have a lot of specificity on really anything that I'm talking about today, but what we're looking for is what exemptions might be available for certain populations, the required number of hours per month, which activities would meet the requirements, such as being a student. There are a lot of questions here. This would have significant IT costs in order to implement work requirements. We'd have to make changes to our eligibility and enrollment system, our claims system, our application portal. We would also need additional staffing at DIVA in order to verify employment and handle all of the additional paperwork that would come with employment verification. That's the fiscal side of things. In addition, we think that there would be savings achieved by implementing work requirements because many people would no longer have Medicaid as their insurance. It would essentially represent a loss of coverage for a significant population of the Medicaid program. We also would anticipate loss of churn in and out of Medicaid and commercial as a result of having employment and then falling off of employment and then coming back into employment. We additionally would anticipate significant access issues as a result of implementing work requirements. We do not have any projections on impact of caseload specifically, though we anticipate it would be focused heavily on the new adult group, which represents a third of our Medicaid population. We don't right now have enough information to run models on what percentage would be eligible under any number of variations of this policy, but as soon as we have more information, we'll be running those numbers. Okay, going into per capita caps. Also very popular. This whole slide is very popular in DC right now, unfortunately. So per capita caps, the idea is that states would, for the first time under the Medicaid program, be at risk for services that Medicaid members received. It would be structured so that we would still be held harmless for the number of people on Medicaid. So the cap would be a per member cap. We are looking for more information here. If caps are assigned per eligibility group or globally, if the formula is cross-subsidizing or cross-eligibility groups, how base year would be defined, how trends and growth rate would be defined, when implementation would occur, how it impacts 1115 waivers that already have budget neutrality caps. We just do not have a whole lot of information. However, Kaiser Family Foundation and Urban Institute have both released models with analysis of a 50-state analysis of per capita caps. And based on what the Congressional Budget Office has projected for savings as a result of this policy, as well as historical spend rates, they're estimating that for Vermont, it would result in around $1 billion over 10 years just through the implementation of these per capita caps.
We're all just taking a collective sigh.
Yeah, I've been breathing this pretty consistently since January, so I really appreciate how significant these numbers are. They're shocking.
Well, let's go on to the
Okay.
next one.
Well, let's just do one more, please, Chair, which I think is already happening. This is the only thing on the slide that is administrative in nature. Everything else would require congressional involvement, but rescinding health-related social needs waiver authority can be done just under the Centers for Medicare and Medicaid Services existing authority. The proposal would rescind HRSN authority that was granted under the Biden administration to pay for 6 months of rent and medical respite. Vermont received waiver authority in January of this year for these two services. We have yet to implement them. Our waiver says that we cannot implement them until 2026. And we have budgeted about $35 million a year for these services in our federal Medicaid budget neutrality agreement. However, we have yet to identify any state matches to fund those services. So this is not a benefit that's off the ground, nor have we earmarked any state dollars for it, but the Trump administration has already removed guidance that was issued on HRSN, and they are very clearly posturing that they will not be allowing HRSN moving forward. Okay, now we can go to.
I think we have a
question.
question. Representative Rebecca?
Did you just change the slide? Is there another page?
There.
No?
Yeah.
Okay.
There is another page.
Ashley, this is so helpful to know. And as you're going through each row, I am really curious and thinking, I hope that AHS is forming some sort of contingency plan of a ranking or prioritization based on either ROI or person of population that benefits on, you know, how to prioritize program cuts that are going to be made, because I think we can say if these cuts are made, but it's realistically more a matter of when they're made, in my opinion. So, you know, if not now, at some point during your presentation, I'll be listening for how AHS is, you know, making those contingency plans and on what basis they are looking at program cuts.
Yes, absolutely. Was there another question?
I don't think so. We're
Okay.
trepidatiously looking not forward to your next slide. So
Okay, let's move on then. The next slide is proposals that were initially floated but are not getting as much traction as the ones that I had just discussed, and we don't need to spend quite as much time on them. But I will say this first one, rescinding 1115 authority, is the one that personally scares me the most in terms of what Vermont has to lose. And this does not require congressional authority. It would be something that Congress could do, or that CMS could do outside of Congress. Right now, we are hearing that Trump administration officials are in CMS asking very pointed questions about 1115 waivers and seem to have a very sophisticated understanding of the flexibility that they afford states. In Vermont, the 1115 waiver brings in $320 million a year in federal funding that would not be available without our 1115 waiver. And it represents huge swaths of our Medicaid program, including all of our 1115 investments, V-Farm, moderate needs, IMD payments to Brattleboro Retreat and the Psychiatric Care Hospital, the CRT program for mental health, qualified health plan premium assistance. It's massive, to say the least. It would also change the entire way that Medicaid administered its program in the state of Vermont. So this one, you know, hopefully will never come to fruition. I think there are states positioning their attorney general's office on how to defend themselves against something like this. It has happened in the past where CMS has rescinded 1115 waivers and states have sued. Some states have been successful, some states have not been successful. So definitely something that the AGO will need to be involved in if this comes to fruition.
Is AHS talking with AGO at this point about this possibility?
Our general counsel, it has a line of communication with the AGO around this topic, yes.
Oh,
That was my question.
Oh, okay. Sorry to jump in before you.
You have chair prerogative.
Thank you. Thank you, Ashley. I think we're all next one.
Okay, so block grants, this is a counterpart to per capita caps. You couldn't have both of them, it's one or the other. Per capita caps, as I said, hold caseload harmless. They only focus on utilization. Block grants focus on caseload and utilization. So not only the services and individuals receiving under the Medicaid program, but the number of individuals that can receive services under the Medicaid program. This would drastically transform what Medicaid is in our country. It would take it from an entitlement to a block grant and would be transformational for our program. We have no sense of what it would look like. If I can be hopeful about it at all, hopeful that they're thinking about per capita caps instead of block grants because it's the lesser of two evils. But just putting this here because it is something that is being talked about in some circles in Washington. Changes in eligibility. One proposal has eligibility renewals happening every 6 months instead of every 12 months. This would be a huge administrative burden on the Department of Vermont Health Access. It would essentially require a doubling of the current eligibility workforce to process twice as many renewals. It would also generate lots of churn and administrative burden for payers and providers in addition to beneficiaries. This reform is so vague, I can barely talk about it, but it's on the table. So what our disproportionate share hospital payments might look like could change. And then something that is already underway through executive action is that the Trump administration has declared that the U.S. will not fund, sponsor, promote, or assist any gender affirmation care for individuals under 19. In Vermont, we have a policy that says we do cover gender affirming care for individuals regardless of age. However, in 2024, we did not have any costs associated with people receiving that care under the age of 19. This would need to be effectuated through regulation rather than just executive order, which hasn't occurred yet, but we anticipate that it will.
Any questions? I have one. I'm curious about IHEP and if there's been any talk federally about removing maybe, I realize we don't actually receive federal dollars for it, but the federal government, Medicaid putting restrictions on states being able to offer Medicaid or any kind of coverage even if it's all state dollars, to undocumented or undocumented persons. If we think IHIP might be at risk from just a policy standpoint.
I certainly think it might be. There were initial, I believe it was in the House in early January, there were initial signs that they might penalize states for using state dollars to pay for people who are not legally residing in the US, which would include IHIP. I haven't heard anything since the very early days of this Congress about that. Doesn't mean it's not on the table, but not something that's currently high on the radar. And I'll also just say, I am in, and Monica and people across AHS are in meetings about this many times a week. We're keeping, as you can imagine, a very close tab on what's happening in DC. We're in very close contact with our congressional delegation. We have affinity groups. We're talking to everyone we can, and notes are being shared with everyone. So this is, as I said, a very dynamic topic, but we're trying to keep super close tabs on it.
I have a question over here, Representative Noyes.
Hi, thank you so much. I know this is predominantly talking about Medicaid, but another program with federal money come in that supports this same population is the Older Americans Act money. Have you heard anything about what's going on with the OAA?
I have not. I am really narrowly focused on Medicaid, but I can certainly flag that for Dale for you.
Thank you.
Okay. Thank you for the really comprehensive and depressing
news, I know.
Thank you. So how do we solve this, Ashley? Is that, I'm hoping, no, probably not.
I unfortunately don't have that answer. But to go back to Chair Wood's question at the beginning around programmatic impact, what levers we have are these 4 that are listed on the slide. So I imagine some combination would be involved if worse came to worst and we saw such significant cuts in our Medicaid funding, which would include backfilling with state-only dollars. Clearly, we don't have enough money to backfill if everything happens, but some amount of backfilling, reducing provider rates, reducing eligibility, and reducing services. Those are what we have to play with if some of these really significant changes come through. So I have a couple of slides here.
Leslie's got a question.
Go ahead.
Well, it would seem to me, as Woody and I are looking at each other, that it would crash the whole system of care in our state. So is there any conversation going on that you're hearing about that is going to address the idea of the implications for our healthcare system for providers, hospitals, et cetera, because there would be no money going to that?
We're having lots of conversations, but as you can imagine, when we're looking at something of this scale, it's hard. They're hard conversations, and there's still so much that we don't know and so much that could happen. If you remember back in 2017, when they tried to repeal the ACA, we went through a similar exercise, and it was extremely, extremely close that they almost repealed the ACA, and it never happened. So that's what I'm holding my breath around.
Yeah, I mean, I'm sure you're talking about it here. I'm wondering if they're talking about it in Washington. Are all your people, you know, their little tags talking about that kind of impact, or they're not?
It's a ripple effect, is what you're saying. Yeah.
Well, I'm just saying the whole system will not exist, as we know. So I'm just wondering if people in Washington are conscious, or they're so absorbed in their own selves that they're not understanding this.
Probably not
So I
something.
can't speak to what people in
Oh, I'm just
Washington
thinking about
are
the tax.
thinking, of course,
Yeah.
but I will say what we're hearing from congressional leadership and what these proposals actually do in reality are not aligned. You know, they're saying they want to focus on fraud, waste, and abuse, and they might want to eliminate some provider taxes and require work requirements and maybe change FMAP, which, if you don't know what that means, doesn't sound all that scary. But when you actually look at what it does to state budget pictures, it's severe.
Thank you, Ashley.
Yeah.
Go ahead, Dan.
So, sorry, I just have, when you talk about the work requirement, that's like anybody who receives Medicaid would be required to work?
So there's
Really
no
nursing homes?
specificity around what this would mean, and presumably there would be carve-outs for people who are aged, people who are children, people who are disabled. We would expect to see those with a national work requirement. What we're most fearful of is that there will not be adequate carve-outs for people with severe mental illness, with substance use disorders, that individuals who are quote unquote able-bodied adults on the Medicaid program would be subject to work requirements, even though they are facing conditions that would make it very hard, if not impossible, for them to hold jobs, which is why when I talk about work requirements, you have to talk about churn and you have to talk about loss of coverage. And it's also why there is a huge congressional budget savings associated with that policy, because they anticipate people not working, they anticipate people falling off of Medicaid.
I'm wondering, what levers do we have? Are you identifying at this point in these levers what would require legislative action? You know, I mean, I think about how we've set rates, eligibility requirements, and even services in statute. So are we identifying things that would require legislative action?
Yeah, I mean, it really is hard to talk about this at such a scale, because it would fundamentally change our entire Medicaid program, which would of course require legislative action. If populations had to be reduced, that's all in statute. We have income eligibility, income percentages in statute. So if we changed who was eligible, that would require statute. If we eliminated services, that would require your involvement. All of it is budgetary. So of course, all of it is going to require your involvement from a budget perspective. But we are making a point to understand what is mandatory, what is optional, what we actually have any ability to do, and what that impact might be on the state side, which is a good segue into these next couple of slides to think about where we can even cut. Medicaid is, as of now, still an entitlement program, and so we do have to have certain populations covered and certain services have to be covered. So on this slide, it's really focused on eligibility, and the top half, the Medicaid state plan eligibility groups and the HBS designated state plan population groups, those receive full Medicaid benefits. They presumably would remain largely intact as populations, though you could imagine potentially changing the federal poverty limit on some of these to be lower if that was a decision that was made in order to accommodate some of the federal budget cuts. So that's one thing, is that, you know, we could lower the new adult FPL percentage, we could lower Dr. Dinosaur eligibility. All of these, we have discretion over how to set that eligibility income threshold. The limited benefit waiver groups on the bottom and the waiver only expenditures are things that are not entitlements. So they're not what we think of as our core Medicaid program. They're available only through our waiver. And those, I think, are a lot more vulnerable to the types of cuts that we're talking about than the top half of the page. So that's V-Farm, the mental health wrap, moderate needs, the marketplace subsidy program, about $160 million a year in investments that go to everything from our health labs to emergency department diversion programs to 211, IMD payments to Brattleboro and Valley Vista and Vermont Psychiatric Care Hospital, palliative care for individuals under 21. Those are all things that are waiver only programs that I think would need to be considered before touching the top half of the slide, which is the core Medicaid program.
Are we running modeling on savings for each of these different groups? Like with
We are.
decreasing, okay.
We do not have anything to share right now. We're in the early stages of really putting numbers to these things and trying to understand how everything plays out. And we'll have more information, I think, later in April.
Actually, whoops, sorry. This is Teresa. I'm just wondering, one of the things that I have been wondering about, because a lot of and I see you cover that in your next couple of slides, but a lot of the services that, thousands of Vermonters rely on in our Medicaid program are really optional services. And has there been any discussion or has there been any sort of hints of, okay, you can keep your Medicaid program, we'll keep the FMAP, but we're only going to allow mandatory services?
I have not heard that at all on the federal level. That's not something that has been floated, from my understanding.
Thank you.
But to lead right into the slide, thank you again. Medicaid is made up of mandatory and optional eligibility groups, and it's made up of mandatory and optional services. So when facing giant cuts, we cannot cut anything in the purple here. These mandatory services cannot be cut in terms of the coverage. We can cut rates for these services. We can slash hospital rates and we can slash home health and we can slash lab rates, but we can't say they're not covered anymore. On the optional side of the house, these are all optional. And so they can be cut. As you see here, some of these feel like they shouldn't be optional, like prescription drugs. That never feels like a viable option when we do this exercise every year to try to fit within a certain dollar amount. We look at this list and we do have an understanding of what each of these optional services cost at current rates, and we can do models to see what rate adjustments are. But just want to put it to these committees to see what we're looking at and what we would have to play with here. It's the populations, the waiver services, the optional services under the state plan, and rates. So these here are like bread and butter Medicaid program. Anyone who's state plan eligible for Medicaid has this. This is like core health insurance. When you think of health insurance, this is what you get in your benefit package. This next slide, sorry, it's a horrible slide, is specific to home and community-based services. And this shows by population what services you're eligible to receive. If you're highest need, you get case management and respite and environmental assistive technology devices, adult day services. if you're CRT, you get crisis support, brain injury has crisis support. So these are other services. They're not available to anyone in the Medicaid program. They're only available to people on HCBS waiver programs. This is another area where we would potentially look at, can we afford to pay for this going forward? These are not mandatory services.
Daisy has a question.
Ashley, is this chart reflecting sort of the new HCBS programming? And can you speak to the new eligibility and any concerns you have with the amount of folks and the cost of that?
Yes, I'm going to stop sharing my screen if that's okay.
Yeah, please.
We keep
You
looking
can
up at
see
you when
me,
you're
like,
not there, so yeah.
physically choking up over this material. So I haven't given a lot of thought into how to visually depict the changes to CRT representative that I think you're referring to. This isn't the most up-to-date visual depiction of what HCBS services look like anymore, but it's the same story in terms of what services would be optional to cut from a federal perspective. If that answers your question. And I don't believe that our changes to CRT and under 21 mental health they're not really impacted one way or the other from the conversation that we just had. It's an optional service kind of either way.
So as a follow-up, when we say optional and mandatory, how hard are those to change by the administration?
They are congressional.
Okay.
They're part of the Social Security Act. Not these home and community-based services ones are 1915, the section 1915 part of the Social Security Act, and then 1905 is where the state plan services are. So they're in two different places, but they would require Congress. The 1115 is what the administration has broad discretion over, and that's like V-Farm and moderate needs and CRT above income.
So actually, do you think, these home and community-based services were sort of succumbed under, they used to have separate 1915C waivers and and then we pulled them in under global commitments in the 1115. Would it be an option then to put them back individually under 1915s if there's some sort of change in what they administratively consider valuable, I guess, or viable under 1115s, or if they decide to discontinue 1115s, because we did have separate waivers for these services previously.
Yes is the short answer to your question. When I think about HCBS, they are not in the kind of highest risk category. They're what we traditionally think of as kind of base Medicaid. They're in our 1115 waiver, but they're authorized through the Social Security Act and through state plan. There are several pathways to cover HCBS.
Okay.
They're still considered an optional service and an optional eligibility group. We don't have to cover them, but it's not as risky as like CRT, for example, which is not a core HCBS service. It's not authorized through 1915. And it is purely 1115 demonstration authority. So I think of them as like two different levels of risk.
Yeah, thank you.
Leslie, did you have a question?
Yeah, but I don't know that Ashley can answer it. But what I'm understanding, just see if I get it right, some of this is related to budget and Congress, and some of it's related to executive order. how do we get a sense of what's what? I mean, do we have federal partners come in and maybe talk to us about that? And how much is dependent on the budget that may be passed in Washington? And what year would that be? So I'm just wondering if we have any breathing room, perhaps.
So we're looking at May at the very earliest that Congress would be moving forward on changes to a reconciliation bill. We think that that would be quite early. It's more likely to be June or July that they would be moving forward on their reconciliation bill. And that's where all of these legislative changes to Medicaid would likely live. There's still conversation about whether it's one big, beautiful bill or whether it's two separate bills and how that looks. Whether Medicaid gets picked up in this 2025 year or whether it would be something that was in 2026. But we're anticipating this summer being a time that a lot of this shakes out.
Does that mean we might need to give authority to HROC or some summer, not us, because we won't be here, group to respond?
That was, to my question of what levers, what legislative action, and are we planning for if things happen when we're not in session, what might be something that we would have to set in place while we are in session?
Yeah, I believe that is underway.
Okay.
Yeah.
Where does that happen?
I'm not exactly sure where, but to give additional authority either to the e-board or joint fiscal committee or some combination to act under certain circumstances, there's so I expect that we'll see some piece probably in the budget bill or someplace. I'm not sure. I know that people are talking about that we need to do that and they're paying attention to it. I don't know exactly where we'll see the language, but we'll see it at some point.
Thank you. That's reassuring.
And actually, I'm going to make a presumption that these impacts are being shared with our federal delegation, that y'all are in.
Absolutely.
Yeah, that's what I was figuring. Just thought I would confirm it.
Yes.
This has been really very, very helpful to have some sort of concept of the total magnitude of this. And I think it's important for us to remember that what you started off with, that next week this could be something different because it's changing continually. So I appreciate that. Other questions?
Just out of curiosity, I know oftentimes various state organizations will have kind of working groups or call groups with other states. Are you seeing, action with a lot of other states to try to stop some of this? We can't be the only ones worried.
We are not the only ones worried. We talk with other states every week, multiple times a week. There are really good groups right now that have been formed since the administration took office, specifically to focus on the changing dynamics in Washington. So we have a couple of different weekly meetings with all of the states and territories where we're trading information and strategizing to the extent that we can around all of this. That's actually been not quite a silver lining, but a really nice product of all of this is the collaboration that's been fostered.
Oh, yeah, Doug. Sorry, we're very
on the question that's about communication with the federal delegation. There's also various folks here in Montpelier. There's Secretary Curley, I think it's been tasked by the governor, the Attorney General, Treasurer Pichek. They all seem to have some groups or action they're taking on trying to keep an eye on just these very questions. Are you or the agency integrated into all of those conversations?
The agency is working very closely with the governor's office and his administration. And then as I said, our general counsel is working with the AGO. I cannot speak to the other groups, the treasurer's office or anyone else that you referenced. I
Thank
don't
you.
have that information. I can certainly follow up if you'd like.
Sure, that would be appreciated. Thank you.
So you said the treasurer's office, and what was the secretary that you mentioned?
Well, I think for the administration, I think it's Secretary Curley who was given point by the governor a couple of weeks ago to be tracking potential changes out of Washington.
Okay, I will follow up.
Any other questions, thoughts? Ashley, thank you so much. This has been really helpful. I feel like I hope you get some good sleep because I have a feeling you've been up an awful lot at night, thinking about these things. And thank you for the work you're doing.
Thanks so much, Ashley. I'm glad you're there.
Thank you.
Thank you.
Thank you,
Thanks for
everybody.
having me, and feel free to ask us to come back later this session as we might know more.
Yeah,
Great.
because it's ever changing.
Thank you.
Thank you.
Thank you. Thank you, Human Services, for joining us.
Yes, thanks for
And-
organizing.